Hi, this is Dr. Gregory Doerr for Functional Soft Tissue, and this month's condition of the month is going to be lateral epicondylopathy. Now, in my opinion, this is actually one of the more frustrating injuries to take care of because frequently what we'll notice with lateral epicondylopathy is actually it's a symptom, not really the problem. And the issue that we're going to have is actually figuring out exactly where the problem may be coming from. For the purpose of these videos for condition of the month, it's actually going to be oriented more towards just looking straight at the lateral epicondylopathy. However, it is important to understand again and reiterate that if you're going through treatment associated with lateral epicondylopathy, within a couple of visits, and I do mean somewhere between 2 and 4 treatments, especially with factor protocols and FTMI taping, as well as rehab, you're not really getting positive results. It's really important to start looking elsewhere in the kinetic chain. Frequently, this may be associated with an asymptomatic unstable wrist. In other words, it's a little bit lax. You may have weakness associated with posterior cuff or scapular stabilizers. These are all areas that we need to look within that kinetic chain that have direct links above and below the joint in order to determine. For those of us who've had these injuries before, whether it be a wrist injury, you'll notice very quickly after spraining a wrist, you're going to start developing lateral epicondylopathy just because the muscle is going to start working over trying to stabilize that injured wrist. And if you have a weak or injured shoulder, you're going to start orienting your arm differently in order to perform your normal ADLs, and that tends to put more strain on the elbow as well. So in particular, looking at the lateral epicondylopathy from a history perspective, some of the things we're going to look at is obviously a pinpoint pain. They may get pain along the forearm as well, but a lot of this tendinopathy is going to be a pinpoint oriented pain. It's also important to understand that these really aren't inflammatory conditions. While we may have some inflammatory experience that's going on around the tendon, intratendinously we usually do not see this as an inflammatory process. It's actually degenerative. It's a tendinosis, where we have granulation tissue that has never gone to full resolution, and basically we've developed a nodular pattern within that tendon, and it's more degenerative. This is why they actually can rupture, not necessarily lateral epicondylopathies, but where we see this elsewhere in the body, like in the rotator cuff or in the Achilles tendon. So important things to also understand regarding this is it's a repetitive strain injury. This is something that tends to be an overuse. It's not a single event scenario. A lot of the times it's somebody who may be working with their hands, but it could be anything from lifting injuries, in other words, repetitive strain associated with weightlifting, repetitive strain, especially for somebody like myself as a chiropractor or any kind of manual therapist, just using our hands all day long can frequently give us a epicondylopathy scenario. People who are typing, whether it be manual labor and or desk jobs, the repetitive strain can eventually develop into a lateral epicondylopathy. So what we're going to look at with the lateral epicondylopathy from an examination standpoint is, let's just start simply by diagnosing the muscle that may be involved. So again, we're looking for pinpoint pain, even though we may get some pain in the extensor wad here, but just testing at the middle finger can frequently provoke pain in a very severe case. So what we're going to do is a single finger press down just to see if that provokes pain. If that's not really as painful or it doesn't trigger symptoms as much, we can go straight into the classic example of just resisted wrist extension. And once again, wrist up, hold there, don't let me push down. Now, if that doesn't provoke pain, what I'll also do is bring the wrist into a full eccentrically loaded position for that tendon. And now I'm going to have the patient push up against me from there. And if that doesn't provoke pain or doesn't provoke the symptoms quite as severely, we'll start in the full concentric position. And I'm going to give that patient full resistance and eventually bring them all the way into an eccentrically loaded position. Now, going from full concentric to eccentric, if that's not enough to provoke pain, you got to question whether or not this is really the injury that you're looking for. Other important things that we look for within this muscle grouping is going to be associated with resisted supination. So we can have the patient hold that position, and what we're going to do is hold there and kind of pull all the way into what would be supinated, and then we can bring them from supinated and now hold resisted supination, hold here, and don't let me pull over. So in that aspect, we can check for resisted pronation and supination to see if that triggers anything at the epicondylopathy. One of the last things that I think is also important to check, especially with your overhead athletes, especially with throwers, is making sure that we don't have laxity associated with the medial aspect of the elbow, because frequently the extensor wad will fire trying to protect the inside of the elbow. So the way that we're going to test this is bring this up to about 20-30 degrees of flexion. We're going to pronate the wrist to take the muscular tension out of the flexor wad here, which will give us a true assessment of whether the ligament is stable. Now from there, he's going to relax his arm, and I'm going to apply my pressure of valgus load by stabilizing at the elbow and then applying my valgus load through the wrist. and that's going to give us an idea of how much gapping goes. I'll put a finger right on the joint line to see if it gaps a lot, and if it's stable, at least we can rule out some kind of a medial collateral ligament injury, and associated with especially our baseball throwers nowadays. Tommy John injuries are so common, which is the tear of that anterior band of the ulnar collateral ligament of the medial elbow. So we want to assess that, making sure that the extensor injury is not actually a protective injury associated with laxity on the inside of the joint. So basic evaluation is accomplished through what we've just done, checking for medial laxity, checking the muscle groups through the extensor wad, and obviously symptom-wise we're going to notice that pinpoint pain. So this is our evaluation and history video associated with lateral epicondylopathy for condition of the month from functional soft tissue. I'm Dr. Doerr, and next video will be factor treatments.